I would like to first of all thank Dr. Amol Bape and the organizers of the 7th International Conference and hands-on workshop on IEE, ESD, and third space endoscopy. And I'm very privileged and honored to talk to you today on my most favorite topic, that is POEM, technical tips and tricks. Needless to say, since its introduction more than a decade back, POEM is now established as almost the primary modality of treatment for achalasia cardia, and there are more than 450 publications on it till date, and probably more than 15,000 procedures being done on POEM all over the world. Technically speaking, to break it up into a stepwise approach and talk to you about the technical tips and tricks, I would like to talk to you about these 10 basic points. And these points are extremely important to make the POEM procedure not only effective, but also a safe. Basically, is a proper patient selection, after which the endoscopist should also assess the esophageal anatomy and the esophageal mucosa before embarking on the POEM procedure. Third most important aspect is a properly planned pre-procedure preparation and some pre-medications which I have been using since the last 10 years from the time we started performing POEM in October 2012 in our country. Intra-procedural preparation, that is the OT setup, and the patient position, the trolley setup, the patient monitoring, etc., are also equally important. The actual steps of the procedure are divided into a mucosal incision and then entry into the submucosal space or the third space, after which the next step is the submucosal tunneling. And after the tunneling is complete, we have to assess that the tunneling is complete. And once that is done, we perform the actual myotomy. Once the myotomy has been achieved, before the mucosal closure, we need to do a meticulous hemostasis. And then the final step is, of course, mucosal closure, which will finally seal the mucosal flap valve. As far as patient selection is concerned, it is extremely important that the patient does not have severe comorbidities which make the patient unfit for general anesthesia. And these two absolute contraindications, that esophageal varices or coagulopathy, should not be present. Esophageal anatomy, the only aspect of esophageal anatomy which impairs or which prevents us from doing the POEM procedure is a grossly sigmoid esophagus, like a S2 or a S3 esophagus, as you can see on the picture on the left. And especially if you have a patient who has got a long-standing achalasia, a dilated tortuous esophagus, and a sump effect, because of which there is almost like a pseudo-diverticulum, and these patients are not going to have an optimal result after the POEM procedure. So even if though technically possible to do a POEM procedure, the results are going to be guarded, and so the patient should be well informed that the patient may continue to have some issues of dysphagia. It's very important before we do the POEM procedure to inspect the esophageal mucosa, make sure that the stomach is also not too inflamed, there's not too much of gastritis, and especially the esophagus, we have to see the esophageal mucosa very carefully. And if you see the pictures, in the upper first three pictures show a reasonably well-preserved mucosa without too much of inflammation, where the chances of submucosal fibrosis, which you are likely to encounter, are less. However, if you have a mucosa like this nodular mucosa or severely inflamed mucosa with ulceration, or this extremely inflamed mucosa, as you can see in this picture, you are going to encounter severe submucosal fibrosis, which can make POEM not only difficult, but it can lead to inadvertent problems like mucosal perforation, or you'll have to abandon the procedure. If you do find a situation like this, we usually postpone the POEM procedure with the patient on a nasogastric or a nasojejunal feed for a few weeks, and then call the patient back, study the mucosa, and once it is healthy, we proceed with the POEM procedure. Pre-procedural preparation and pre-medication is very important. A few days before, 2 days before, the patient is kept on clear liquids orally. 1 day before, we have to do an upper GI endoscopy, do a proper washing of the esophagus until it is absolutely clean of all the debris and the collected food. And the patient is given a proton pump inhibitor and a tranquilizer on the previous night, so that the patient does not have too much of anxiety and does not raise the blood pressure during the procedure. On the day of the procedure, it is our routine practice to give the patient 100 micrograms of clonidine to keep the blood pressure under control, and probably even a hypotensive anesthesia, less than 100 systolic. And in addition to that, we give 75 to 100 milligrams of pregabalin to prevent post-procedure chest pain, which can occur because of the cut nerve endings in the esophageal muscle. And of course, PPI, as well as some antiemetic. In the operation theater, in the endoscopy room, we usually perform all the procedures of POEM in the supine position because I do a posterior approach. If you are doing an anterior approach, you can keep the patient left lateral. There's a special mouthpiece which has got fenestrations at the sides through which the introtracheal tube can go. You see here, this is the placement of the patient monitor, the endoscopy monitor, as well as the instrument trolley. The assistant stands somewhere over here. On the patient monitor, these are the values which we need to constantly monitor. There is the pulse rate, then we have the oxygen, then we have the respiratory rate, we have the PCO2 and the blood pressure. We have to make sure that this is usually under control. The pulse rate should always be low and the BP should be low. We have to keep a check on the PCO2, and if it goes beyond 40 to 45, usually we need to stop the procedure. That means there's too much of CO2 leakage. Wait for a little while until the PCO2 reduces and then continue the procedure. On the patient trolley, here you can see we are using the TTJ knife. You have got the coag grasper, the injection needle, the TTJ knife, and this injected solution, which is nothing but normal saline mixed with indigo carmine. And the amount of indigo carmine mix should be such that the color is pale blue or it is sky blue. Diathermy settings on C, we usually use endocut Q, effect 2, 3, and 3. That is cut interval and cut duration 3, effect is 2, or you can use even the precise sect. For control of CO2, we use this very simplistic mechanism of a small bivalve, and you can control this by rotating this knob and have a very, very controlled carbon dioxide flow. The basic step is, of course, the mucosal incision, which is started 10 to 15 centimeters above the esophagogastric junction, depending upon the subtype of achalasia which you are going to treat. Type 1, we try to do a small esophageal body incision. So therefore, a longer or a shorter tunnel is required. In type 2, we have a medium length tunnel, whereas in type 3, usually a very long tunnel is required to cover all the spastic contractions of the esophagus. After cutting the mucosa using whichever knife, the next important point is to cut the lamina propria or the muscularis mucosa and to make proper ledges below both the vertical margins as well as the apex of this cut. Only when you have done a proper ledging of the apex as well as the vertical margin, then it becomes extremely easy with a simple rotation of the scope to enter inside the submucosal space. Once we have entered inside the submucosal space, we are going to see the submucosal fibrous, areolar tissue. However, in case the mucosa is abnormal, it is quite thickened or it's quite inflamed, right at the mucosal incision itself, you are likely to have a situation like this, where you may encounter bleeding at the time of incision. In such a situation, one should not panic. You should just use coagulation current, that is forced coag. Keep on extending this incision, and then after you have extended the incision, we use a coag grasping forceps, catch hold of the vessel which is bleeding so that it prevents the irritating bleeding and prevents your view from getting disturbed. Achieve a proper hemostasis, extend the incision, and then we can perform the procedure further. Sometimes, if there's too much of submucosal fibrosis, it is difficult to enter inside the submucosa. Here, the dissection has to be very, very careful. You have to keep on giving forced injection of the injectate. Try to raise the submucosal tissue, increase the fluid cushion. If that is not possible, we rotate the scope and enter inside in a different method, exactly in the opposite direction. And even after doing this, we have to very, very gently dissect these layers, because here you can see that there is a dense submucosal fibrosis. And if you just keep on pushing the scope ahead, you can just enlarge this mucosal incision and make it into a large tear, and then it becomes difficult. So it's very important to select these patients. If you find mucosal edema or erythema or a thickened mucosa, you are going to encounter submucosal fibrosis. So we should not proceed with POEM immediately. Give a gap for a few weeks with feeds and then go ahead. Inside the submucosa, making the tunnel is just a movement which is from left to right and from right to left by a movement of the shaft of the endoscope. And the trick here is to stay as close to the muscle as possible. By doing this, we are achieving two things. We are going to protect the mucosa and we are going to expose the circular muscle fibers. If you encounter small blood vessels like this, which are smaller than the size of the knife, tip of the knife, you can just coagulate it by coagulating just by the side of the vessel into the fluid cushion and then continuing your dissection. As you continue the dissection, all that you have to do is to follow perpendicular to the circular muscle fibers. If you encounter big blood vessels like this, then this needs to be coagulated by using the coag grasper. Using the coag grasper, it's important that you should catch the vessel exactly at the place where it is emerging out of the muscle layer. Now, this is the best place to coagulate it, and we should always use forced coagulation because this causes lesser deep penetration of the diathermy, heat. After coagulating this vessel, you can see once this vessel becomes whitish, which is indicated, which shows that it is completely coagulated, then using the same coag grasper, we cut it and we go ahead and continue our dissection until we reach the esophagogastric junction. The main aim is to go beyond the esophagogastric junction. Sometimes while doing the tunneling, you may find dense fibrosis like this, where, as I mentioned before, you keep on injecting the fluid with greater force, and the best landmark is to go at the place which is blue, which indicates that the fluid is entered. If you don't see any blue color, that means this mucosa is firmly adherent to the muscle. Don't try to dissect at that level, and you keep on dissecting at the level of the blue until you achieve a plane, and this way you keep on going ahead and you complete the tunnel. So this is how we do in patients who have got dense fibrosis. Well, how do we assess the completion of the tunnel, and what is the two vessel penetrating sign? You see here that as we keep on dissecting this, we keep on going ahead at perpendicular to the circular muscle fibers until you reach the OG junction, and you two penetrating vessel sign. You can see these vessels which are coming out from the mediastinum, penetrating the muscle and going across the submucosa towards the mucosa. I usually coagulate this vessel so as to make this area free, and I can go deep inside and properly inside the stomach. Sometimes you can go by the side of these vessels, but there is a risk that as you are manipulating the scope by the side of the vessel, you can tear the vessel and it can lead to very brisk bleeding. Even if you coagulate these vessels, there is no harm. So once we go ahead, we keep on dissecting a little bit ahead, 2 to 3 centimeters beyond the esophagogastric junction, until you start seeing these type of fibers, which are very classical of the stomach muscle fibers, and you can also see some palisade vessels. Now, after you have done that, once you feel that you have achieved a good tunneling, then you have to pull the scope back inside the lumen, and you go inside the lumen and then try to see whether you have achieved a complete tunneling. By taking a U-turn, you will be able to see that there is a whitish or a bluish bulge, which is on the lesser curvature side. This can also be done by the double scope technique by using another ultra thin scope, and by trans-illuminating the light through the tunnel, we can come to know that your tunnel is completed. Once this is done, then the time has now come for the myotomy. So for the myotomy, I usually begin, depending upon the subtype of achalasia, either 10 to 15 centimeters or sometimes even longer, above the esophagogastric junction, and I usually begin the myotomy using a forced coagulation current. So by using the forced coagulation current, as you can see here, I usually perform a full thickness myotomy, but it is individual preference. You can either do a partial thickness myotomy till the lower end, and only in the LES area you can perform a full thickness myotomy. So this is how the myotomy is completed. The end of the myotomy, the muscle fibers, I usually cut by using the coag grasping forceps, because here we have not done the tunneling above or below the muscle, and therefore we can prevent damage to any vessels which are surrounding this end muscle, which is just beyond at the end of the tunnel. Once the myotomy is completed, we perform a closure by applying a series of clips. And as you can see here, for applying clips, the first clip which has to be applied is the sentinel clip, which is at the apex of the cut, and then one clip after the other, we keep on applying these clips until we can achieve an almost watertight closure. Even the POEM is a relatively easy technique for a person who is used to doing it. We can encounter difficulties like bleeding while performing the dissection. You can see here bleeding during the tunneling, which can be tackled quite well by using the coag grasper. One should not panic, just keep on irrigating fluid, gently observe the vessel, catch hold of the vessel very superficially, then pull the coag grasping forceps behind and then coagulate it using the forced coag. It's always better to use the forced coag current because it causes lesser penetration inside the tissues. You can have even a bleeding which is occurring from the cut edge of the muscle, or you can have bleeding which is occurring from the mediastinal bed. Very rarely, if you have not selected the patient properly, or if you're too hurried in your approach, and if you don't take care of the mucosa, you can achieve a mucosal breach, or you can create a mucosal breach. Usually, it is better to close this mucosal breach, but if you continue to do dissection, in spite of the mucosal breach, it can happen so that you can extend this mucosal breach instead of, you can see here the mucosal breach is extended. So what is the better technique to do is to come inside the lumen, close this mucosal breach by putting a series of clips, and then after that you can continue your dissection. Or if the dissection is difficult, just simply abandon the procedure and call the patient back later and perform a POEM in the opposite direction a few weeks later. So finally, in conclusion, I would just like to state that the POEM is a really wonderful procedure. And to tell you the truth, it is genuinely a landmark invention in GI endoscopy of the last decade. And it has caused a paradigm shift in the management of achalasia cardia. What is most important, as I mentioned before, is a very proper patient selection, a careful assessment of the esophageal anatomy and the esophageal mucosa before you embark on the POEM procedure. Your technique has to be very, very meticulous and extremely precise because you are dissecting inside the chest, next to the lung, next to the heart in case of anterior POEM. And of course, as any good adventure person or any good mountaineer, we have to anticipate and treat complications. So anticipation of complications is very important. You should be able to see vessels before you cut them to anticipate and secure treatment of complications. Finally, I just want to say that POEM has changed the way now that we treat achalasia cardia. It has opened up a completely new horizon of interventional endoscopy. And I'm sure that this technique is going to pave the way for the future of the new specialty of endoscopic surgery. Thank you for your attention.
Thank you very much, Dr. Maydeo, for such